Good morning and welcome to today's program titled, Can You Compete? Best Practices for Non-Advanced Systemic Mastocytosis. We're honored to have participants from across the country here today, not only in this room, but also viewing online. This program is supported by an independent grant from Blueprint Medicines Corporation. Everyone in the live audience should have the following items at their place setting. A card with a QR code, which will give you access to program slides, accreditation, and disclosure information, as well as a library of valuable clinical resources. A two-sided program evaluation form. Please be sure to complete and return this form to the ushers at the conclusion of this program. A keypad to respond to polling questions throughout the program. Your responses are anonymous and very important to the educational outcomes of this program. For everyone joining us at home online, all this information is located on the right side of your screen under the Handouts tab. The evaluation will automatically open in your web browser following the conclusion of the program. For our live audience, if you would like to ask a question during the presentation, please write it down on the question card located in front of you. Ushers will be collecting them throughout the program. If you're at home, you can submit questions through the Q&A box on the right side of your screen. Now, let's give a warm welcome to tonight's presenters, Dr. John Fahrenholtz, Dr. Matthew Giannetti, and Dr. Tanai Pongdi. Enjoy the program.
All right, welcome everybody. Mike, everybody can hear. Great. So my name is Matt Giannetti. I'm assistant professor of medicine at Harvard Medical School and Brigham and Women's Hospital. And I'm here with two colleagues. I'll let them go ahead and introduce themselves.
Good morning. My name is Tanai Pongdi. I practice at Mayo Clinic in Rochester, Minnesota. We'll hear about the teams in a moment, but I really need my team to pay attention. So we have a little side bet going on, so I really need you to win for me.
I'm John Fahrenholtz. I'm assistant professor of medicine at Vanderbilt University and Team Yellow here today. And I think we were announced that it was tonight. As we all know, it's very early in the morning, but go Team Yellow.
All right, and then I'm going to be the host, inferior to Alex Trebek and probably Will Ferrell from SNL as well. But nonetheless, let's get going here. Okay, here are disclosures for all three of us. Learning objectives. So we would like to discuss the causes and consequences of non-advanced systemic mastocytosis, focusing on potential clinical manifestations and the rationale for new targeted therapies. Differential diagnosis of SM, including indolent disease based on symptoms and appropriate use of laboratory and genetic testing. Describe the recent clinical trial evidence and regulatory status for targeted treatment options in non-advanced SM. And then finally, individualize therapy for patients with non-advanced SM to reflect clinical evidence for efficacy, safety, patient-reported outcomes, and shared clinical decision-making. Okay, so before we start and get into the game, a couple pre-test questions. So we're not going to go through answers here, but I'll pause for a minute and allow the audience to answer the pre-test questions. Okay, one more pre-test question. Number two, for what percentage of your patients with non-advanced SM whose symptoms are uncontrolled using standard of care therapies such as antihistamines and cromolyn, do you currently prescribe a tyrosine kinase inhibitor to treat their mast cell burden? All right. So let's get into the rules of the game. Everyone has been assigned to a team, and Dr. Fahrenholtz on the left and Dr. Pongdi in the middle are your team leaders. So if you look in the center of your table, you'll have some either green pom-poms or yellow pom-poms. Dr. Fahrenholtz will represent the team yellow, and Dr. Pongdi will represent team green. Very enthusiastic. Team green is leading here. Your team leaders will take turns choosing a category and dollar amount, and all learners will respond to each question using the keypad at their seat. So these two up here are going to choose, questions will display, people answer the questions, and then we'll kind of move forward. At the end of the game, the team with the highest percentage of teammates who chose the correct answer will win the round. And a coin toss happened before while everybody was drinking coffee and eating the breakfast. And Dr. Fahrenholtz won, therefore he gets to choose the first category. Okay, so categories, 5 categories. By the numbers, the early bird gets the worm, targeted avenues to treatment, the 3 Ps, patient education, patient experience, patient monitoring, and Tracy Talks, courtesy of Tracy George. Let's hear a little intro from Tracy here.
Hi, I'm Dr. Tracy George, Chief Scientific Officer and Medical Director of Hematopathology at ARUP Laboratories in Utah. I'm going to be explaining the answers to the systemic mastocytosis pathophysiology and diagnostic questions in this category.
Okay, so since Dr. Fahrenholtz won the coin toss, I'm going to hand over to Dr. Fahrenholtz for the very first question.
Very exciting. All right. Team Yellow, let's see. Let's start with by the numbers for 200, please.
Okay. By the numbers for 200, approximately 1 in blank people in the United States are living with SM. Number 1, 100, 2, 1,000, 3, 10,000, and 4, 100,000. So audience, as we're going through the first question, go ahead and click your responses. All right, looks like kind of an even split here between 3 and 4. We'll go ahead and hand over to John for some education.
Okay, so systemic mastocytosis, it is a rare clonal mast cell disorder, but not quite as rare as another disease we take care of. So the answer number 4, which some of you chose, the 1 in 100,000, probably fits better with hereditary angioedema, or those ranges have ranged from like 50 to 100,000 or maybe around 80,000. So mastocytosis also is a rare disorder, but affects approximately 1 in 10,000 patients, individuals, non-advanced being the vast majority of those cases, with approximately 90% having non-advanced indolent. Now we break out bone marrow mastocytosis, meaning bone marrow involvement without cutaneous lesions characteristic of urticaria pigmentosa. Smoldering is an in-between category, and as you can see, approximately 10% of patients will have the more aggressive version of the disease. There's no apparent gender or ethnic bias in the distribution of patients.
Okay, yellow wins.
Now shake the pom-pom. Way to go, yellow. All right.
All right, so score, Team Yellow, 200, Team Green. I don't think you guys get to see the actual percentages of the answers, but behind the scenes, they actually are calculated. Okay.
All right, let's go Team Green. Let's go for Tracy Talks for 200.
All right, Tracy Talks, 200. The KIT D816V mutation is found in approximately blank number percent of patients with non-advanced SM. So 1, 25%, 2, 50%, 3, 75%, and 4, 95%. All right, looks like the majority have answer number 4. Let's see what Tracy has to say.
Thanks for choosing my category. The correct answer is 95%. So 95% of patients with non-advanced systemic mastocytosis have the KIT D816V mutation. This mutation results in activation of the receptor, and abnormal signaling pathways are turned on. These signaling pathways control mast cell differentiation, maturation, migration, proliferation, survival, and cytokine production. Triggers of the mast cell include allergens, infections, cytokines, drugs, peptides, and other toxins. These result in degranulation of the mast cell with release of histamine, tryptase, and numerous other pro-inflammatory and vasoactive mediators.
Yellow again wins. Also, boy, I think I need to recruit Tracy for my clinic. I would love to have like a TV screen here and, pop on Tracy Talks. Okay, so Team Yellow, bigger lead, 400, Team Green, 0. All right, John, back to you.
Yeah, I'm liking Tracy too. Let's go Tracy Talks for 400.
All right. Tracy Talks, 400. Heparin, histamine, and tryptase are all mediators released by MCs when triggered. 1 true, 2 false. Oh, fantastic. Heparin tricked nobody.
Thanks for choosing my category again. The correct answer is true. So environmental stimuli activate the mast cell. This results in release of preformed mediators such as histamine, tryptase, heparin, lipid mediators, as well as various chemokines and cytokines. The clinical consequences of mast cell mediator release depends on the mediator, but essentially you will get cardiovascular symptoms, cutaneous symptoms like flushing and urticaria, respiratory symptoms, digestive symptoms, neurologic, musculoskeletal, as well as systemic symptoms, as shown on this slide.
Finally, great. Green wins here. Okay, so score is now tied. Team Green has 400. Team Yellow has 400 as well.
Thanks so much, Team Green. I have a lot riding on this personally, so thanks. Let's go by the numbers for 400.
They don't give us more money if we win, though. By the numbers, 400. In a survey of patients with SM, most of whom have a non-advanced subtype, what was the average number of SM-related symptoms the patients reported having had through the course of their disease? 1, 4 symptoms, 2, 9, 3, 14, and 4, 18. All right, the majority report 9. Some have 14 as well. Let's move forward. Oops.
So the answer is 14. This really speaks to the vast number of symptoms that patients can experience. So we really need to recognize really the whole patient when we evaluate SM. We really need to think of the whole individual. We tend to focus more on the things that we can see and listen to, skin, heart, lungs, and such. But a lot of the generalized constitutional aspects are very important as well that affect really their daily life. And also speaks to the difficulty in making a diagnosis. So as you can see, a lot of these symptoms would be fairly common in isolation in the general population. So we really have to have a high index of suspicion when we're seeing these patients in clinic. There was one survey here that looked at the most bothersome symptoms. You can see that at the top was anaphylactic episodes, which makes a lot of sense. Obviously, these could be near fatal events, very scary. And personally, many patients, they're just terrified to go out. Can I eat this? Is this going to happen to me again? when I tell people in the emergency room, they don't know what I'm talking about. They never heard of this diagnosis or heard about it in medical school. So again, a very scary experience for our patients. So you really think about, being the resource, kind of the home for these patients in your clinic. There are a number of quality of life and symptom tools. All these are validated measures you see on the screen. You should consider using these in clinic. They may take some additional time in your workflow, but would give you some objective measure to follow rather than just kind of a subjective qualitative measure when you see them. I'll speak more to the tool on the right. So this was the scoring system used in one of the large clinical trials that will be discussed later. But how this worked, there you can see the symptom domains. There's 11 symptom domains, and you can score this from 0 to 10, with 10 being the worst you've ever felt. And then in aggregate, it goes from 0 to 110. So the purposes for the clinical trial, this is the Pioneer trial, which we'll get to, like I said, later. Greater than equal 28 was required to be entry into that trial. But just so you have some reference for the scoring system that was used.
All right, and green wins.
Thank you so much.
Okay, so Dr. Pongi's team out in front, 800 to 400. Dr. Fahrenholtz, back to you to select.
All right, let's go. Early bird gets the worm, 600.
Okay. The early bird gets the worm. Which of the following is a potential trigger of mast cell activation? Hymenoptera sting, contrast dye, age greater than 70 years, and alcohol consumption. Please note this is a select all that apply question. All right. Alcohol, most of our patients maybe are not drinking. All right, Dr. Fahrenholtz, let's see what you have to say about this.
All right, thank you. I would like to go back to the prior question for a moment because I think it was a trick question that green ended up winning. I think, you saw the symptom score. You saw the symptom score, 11 categories. The answer is 14, cumulative over a lifetime. I think we probably had that correct and should have won that had it been a better question.
He's already trying to rationalize things, so please stay focused, Team Green.
All right, Yellow. Here we go. So I think something that's highlighted a lot in terms of triggers, and they can be non-IgE mediated and IgE mediated, and of course mastocytosis patients can have both. Venom allergy is a common trigger that's discussed as mastocytosis patients have a high risk of severe anaphylaxis with Hymenoptera stings. And in fact, as we know, it's a key consideration in the history of a patient with venom allergy is looking for underlying mastocytosis, in particular if that insect sting was very severe. And I think we'll come back to that a little bit and make that point later in some more detail. Alcohol consumption, NSAIDs, viral, bacterial infections, you can see a lot of these things, emotional, physical pain, and often cofactors come together in my experience. So somebody who's out in the hot sun golfing and maybe drinking a lot of alcohol and then taking NSAIDs because they're anticipating trouble, then they have anaphylaxis. In fact, I had a patient like this who about every 6 months would get together with buddies and do that type of activity. And he was brought in by his wife, and turned out, indeed, he had an elevated tryptase and mastocytosis, but only anaphylaxed if he added multiple triggers. Next slide. We're going to talk a little bit about surgery. So perioperative management is important. There are some factors that can be modified, and the anesthesiologist and the surgical team being involved. These patients tend to scare surgeons and some anesthesiologists if they're not familiar with the disorder. You can provide them with some information, and later in the presentation there's a slide that talks a little bit more specifically about some medicines that are preferred versus not preferred. I'm just highlighting a few here in terms of quote-unquote safer agents. The only opioid that does not trigger mast cells is fentanyl. So for severe pain, fentanyl would be the go-to, as opposed to, say, morphine, which does trigger through the MRGPRX2 receptor. Tramadol, important, the sound of like Toradol is a highly potent NSAID, so Toradol you don't want to use, generally speaking, unless it's been tolerated before, but Tramadol is a narcotic-like pain medicine that is generally tolerated. Ketamine, propofol, benzodiazepines are usually well tolerated as well. All right, that's what I'm talking about.
Yellow.
All right.
Team yellow in the lead, 1,000. Team green, 800.
All right, don't get distracted, Team Green from Team Yellow. He's trying to distract you. All right, let's really go for it here. The 3Ps for 1,000.
All right, 3Ps, 1,000. How do patients with non-advanced SM feel about having to use epinephrine to manage anaphylaxis? 1, ambivalent. 2, love it. And 3, hate it. All right, the majority chose hate it. We have a video.
When you have anaphylaxis and somebody gives you epinephrine, sometimes you lose all control of your bodily functions, and that can be humiliating. It could be very hard. It's scary. Your heart goes so fast. You feel like you might not live through this. You lose control of your urinary tract, of your bowels, and you can start vomiting, and the nausea sets in, the shaking. It is a very, very hard experience to go through when you have anaphylaxis. And there's so many different stages of it. Also, it could be to, where your throat isn't actually closing up, but other bodily functions are not working. Once the epinephrine is in your system, and you have to let it go through your system, there's so many things going through your mind. You feel like your body's being shut down. And it is something that, unless you experience it, it's very scary.
So, is Mary Jane's anaphylaxis experience similar to what you have heard from your patients with SM? We'll have a group discussion here. Maybe we start with John and move to Nye.
Yeah, I absolutely think so. Anaphylaxis is something that doesn't happen to all patients, but in those that experience anaphylaxis, it is a terrifying situation, and many people are really marked by that, especially spontaneous anaphylaxis events that are coming from no apparent trigger. People will almost get a situation where they have a PTSD-like feeling about it. It can be very traumatic, and the use of epinephrine, while very important, is not something that people enjoy doing, obviously. So, I think most people hate it.
Yeah, I would echo those sentiments. I think just the unpredictability of it. In most cases, it's a sporadic, random event. And again, my patients, it's a very traumatic, and it's paralyzing in terms of carrying on, your daily life. So again, recognizing this, in the busy clinic throughout the day, to take some time to really focus on these issues.
Yeah, in my experience, I would agree with this. It's pretty rare that I have a patient where I'm discussing overusing epinephrine. Almost always it's a situation where I'm saying, hey, you had this episode, it would have been better if we used epinephrine here. And I think much of that does stem from patients' fear of using epinephrine. So I absolutely agree with the hated answer. Okay, everybody wins. Excellent. 1,000 points for everybody. Okay, so we are now at Team Green, 1,800, Team Yellow, 2,000. And I think this one here is back to Dr. Fahrenholtz.
Yes, well, let's go early. Early bird gets the worm for, or wait a minute. Yeah, 800. Let's do 800.
All right, early bird gets the worm, 800. Allison, a 45-year-old woman, presents with recurrent urticaria, flushing, and one prior bone fracture, a vertebral fracture, which is not fun. During her assessment, it was found that she previously had anaphylaxis in response to a wasp sting. What should be the next step in Allison's care? 1, perform a bone marrow biopsy. 2, measure serum tryptase level. 3, measure alkaline phosphatase level. Or 4, test for hereditary alpha-tryptocemia. All right, 85%, measure serum tryptase level. Let's see what Dr. Fahrenholtz has to say about this.
I agree. Yeah, I would measure serum tryptase level. It's the place we generally start in a patient in whom we're suspecting mastocytosis. We've talked about severe anaphylaxis, even apart from chronic recurrent mast cell mediator symptoms. And in adults who develop new onset urticaria pigmentosa, or as we say, maculopapular cutaneous mastocytosis, I still prefer urticaria pigmentosa. It's easier to say, but those are patients that we're looking at. Now, this slide seems to suggest that we're moving toward bone marrow biopsy perhaps right away, but that's not the case. And as we saw in this situation, generally we would measure a serum tryptase as the starting point and then follow that up with other specialized testing, depending on the results of that and specific patient history. So REMA score is just something we wanted to touch on. This is a score that was developed by a group in Europe, and it looked at the likelihood, based on these characteristics, of a diagnosis, high probability of systemic mastocytosis. So some of the things are a bit surprising. Perhaps, like, men, you get a +1, women get a -1 in terms of the likelihood of the diagnosis. I think this speaks to the fact that, like, my patient had to be brought in by his wife, and so if a man actually makes it in for evaluation, I think they're more likely to have it because they don't come into clinic perhaps as much as they should. This is interesting. So chronic urticaria, pruritus, angioedema, that phenotype is usually not what we see in mastocytosis. So if the absence of urticaria and angioedema, not so much pruritus per se, but just the chronic urticaria patient that we typically see more commonly is not the patient that's likely to have mastocytosis. And the other, the largest number in the positive direction would be presyncope and syncope. Now, that would be in the context of an anaphylactic reaction, and the most severe anaphylactic reactions often lack urticaria and angioedema, so that's where those numbers come from. And then you can see that basal serum tryptase greater than 25 gets 2 points, less than 15 gets -2. We're going to touch on hereditary alpha-tryptocemia later, so I won't get into that now. Next slide.
Green wins. All right. So here we go. Team Green, 2,600. Team Yellow, 2,000. All right.
Keep it up, Team Green. Keep that coffee going. Let's go Tracy Talks for 600.
All right. Tracy Talks, 600. Which of the following assay types has the highest sensitivity for diagnosing systemic mastocytosis, especially in the case of low variant allele frequency, VAF? 1, next generation sequencing. 2, Sanger sequencing. 3, droplet digital PCR. And 4, flow cytometry. All right, ddPCR, there seems to be agreement. Dr. Pongdi, let's see what you have to say about this.
Welcome back to my category.
Excuse me, Tracy.
The correct answer is droplet digital PCR. The testing standard of care of systemic mastocytosis encompasses a number of different categories. These include laboratory testing, as shown in the upper left, morphology, looking at blood, bone marrow, aspirate smears, and biopsies, phenotype of the mast cells, as shown in the lower right, and genetics. High sensitivity mutation analysis for KIT D816V is essential for this disease. There are a number of molecular techniques to assess the KIT D816V mutations. For example, PCR assays can be quantitative or qualitative. Qualitative assays identify the presence or the absence of a mutation, so a yes or no answer. But quantitative assays analyze the variant allele frequency, or VAF, of the mutation. And there are a number of different correlations between the KIT allele burden and clinical parameters. There are other types of techniques as well to assess the KIT D816V mutation. There's Sanger sequencing, but this has a sensitivity down to about 20%. There's next generation sequencing, and this is better. The sensitivity is approximately 2 to 5% depending on the laboratory. But if the VAF is low, such that there's a minor mast cell burden in the bone marrow, NGS is often not sensitive enough. So high sensitivity quantitative assays for KIT are necessary. These include digital droplet PCR or allele-specific oligonucleotide quantitative PCR. And the sensitivity of these assays is down to approximately 0.01%. In one abstract, ddPCR detected the KIT D816V mutation in 95% of blood samples versus 28% by NGS. Thus, there was a 30-fold greater sensitivity over NGS for measuring VAF, and this was in a population of patients with indolent SM. There are a number of benefits of high sensitivity assays. These are the most reliable for KIT D816V analysis, especially with a low VAF. Quantitative PCR methods should also be assessed in bone marrow samples if the initial measurement in peripheral blood is negative. And that's because some SM cases, especially in ISM, are negative for KIT D816V in the blood, but positive in the bone marrow biopsy. These high sensitivity assays are recommended by different guidelines to avoid false negative results. And when choosing a laboratory to analyze blood and/or bone marrow biopsies, ensure that the laboratory is skilled at high sensitivity PCR assays, mast cell flow cytometry, and mast cell immunohistochemistry.
All right, yellow wins.
All right, yellow.
Okay, tied up, Team Green and Team Yellow, 2,600. All right, Dr. Fahrenholtz.
All right, let's go early bird gets the worm, 200.
Okay, early bird gets the worm, 200. Keith, a 59-year-old man, presents with 2 recent episodes of anaphylaxis from a jellyfish sting and from iodinated contrast dye. In a follow-up with his allergist, Keith's serum tryptase was 23.8 nanograms per milliliter, but he did not have any skin lesions. Peripheral blood genetic testing revealed that Keith is positive for the KIT D816V mutation. What would be the next appropriate diagnostic step for Keith? 1, measure alkaline phosphatase level. 2, test for a somatic mutation in P53. 3, order a skin biopsy. Or 4, perform a bone marrow biopsy. All right, excellent. That was a softball question. Dr. Fahrenholtz?
All right, so this slide gets into the decision to perform a bone marrow biopsy. It's a little early for all these arrows, but I'm going to talk through this. So this slide and this particular algorithm would apply to adult patients. As we've talked about, if an adult patient develops urticaria pigmentosa, that is a significant risk factor, and it's considered that the majority of patients who develop adult onset urticaria pigmentosa will have systemic mastocytosis. And so if they have new skin lesions as an adult, yes, you're going to order these tests. So the serum tryptase, like we've talked about, in order to risk stratify a CBC with differential, I'll usually order a comprehensive metabolic panel as well. And then the high sensitivity kit, DH16V, mutation test, which we can do on peripheral blood, as Tracy was so eloquently describing to us. Now, in terms of when to order a bone marrow biopsy, this would suggest that in most cases, yes, you're going to perform a bone marrow biopsy in this patient, assuming that you're probably going to find something abnormal with tryptase or high sensitivity kit. However, something that comes up, and it's not rare in my experience, is a patient in whom you do these tests, their serum tryptase is completely normal, their high sensitivity peripheral KIT mutation is negative, and all their labs are normal. And so the symptom they have is cutaneous mastocytosis, and in all of those patients, do you perform a bone marrow biopsy? I think you can have a careful discussion with the patient, and in some cases, you don't have to go right away to bone marrow biopsy. I think not everybody would agree with me on that, but also often patients would push back on a bone marrow biopsy in that sort of situation as well. You need to monitor them carefully, probably initially every 6 months, repeating tryptase, CBC, and diff, maybe repeating the KIT allele fraction. That can be a marker of more mast cell burden, and then thinking about bone marrow biopsy. So if we go down the other pathway, no skin lesions present, so no urticaria pigmentosa, it doesn't mean that they don't have cutaneous symptoms. Then the key question is, have they had severe recurrent mediator symptoms? Osteoporosis, osteopenia is another risk category, as in men who present with osteoporosis without other symptoms, that actually is considered a risk for mastocytosis and should be evaluated. So if they have symptoms, then you would check the tryptase, the labs as we've seen on the left-hand side, and then if tryptase is greater than 20, which would fit the minor criteria for systemic mastocytosis, you would move forward with a bone marrow biopsy. If the tryptase level is normal, less than 20, you would perform the KIT DH16V high sensitivity testing. And if the mutation is detected, then you're doing a bone marrow biopsy. If it's not detected, then you're in a situation where it's really the clinical history, and you have to dig into some of the details here. Some patients will still need a bone marrow biopsy, and I think that's the population who have had anaphylaxis with cardiovascular collapse, and particularly if that's a stinging insect reaction. So you might even consider anaphylaxis, cardiovascular collapse, all these tests being normal, but still moving forward with the bone marrow biopsy and select patients after careful discussion, or at least monitoring them quite closely. Other considerations, I think Dr. George has already touched on this in terms of NGS or next generation sequencing. That's pretty standard. I think when we order a bone marrow biopsy, the pathologists want to do that to look for evidence of other myeloproliferative disorders. And then obviously the hematopathology lab needs to be familiar with doing these special stains, et cetera.
Okay,
right.
Yellow wins.
I think that puts us just in the lead, team. All right.
Team Yellow
I
is
noticed
up.
a few yellows that don't seem to be clicking. I want everybody to be clicking, please.
Dr. Pongdi, over to you to select the category.
Green, we need to stop the momentum. Let's go by the numbers for 800.
By the numbers, 800. What percentage of the general population has duplications of alpha tryptase in the TPS-AV1 gene, resulting in hereditary alpha tryptosemia? 6%, 12%, 18%, or 24%? Keep in mind here the question is general population. Great, 82%. Dr. Pongby?
I think this is a great topic to touch upon. We've heard a lot about hereditary alpha-tryptophanemia in the last few years. So this slide illustrates a few good points to keep in mind. It is an autosomal dominant condition, and as far as we know right now, it's found in about 6% of the general population. That's mainly been a North American and Northern European population, so we really need to expand our look in other populations. So this is what we have. So I would keep that in mind in terms of the 6% number. Again, it's due to duplications in the gene encoding alpha tryptase, which when you're measuring baseline serum tryptase levels, you're measuring the constitutive secretion of these pro-alpha tryptase, alpha and beta tryptases. So what we find in general, if your baseline tryptase number is greater than 8 nanograms per milliliter, other than mastocytosis, another potential explanation could be hereditary alpha-tryptophanemia. There's some, in terms of the data we have so far, it seems like every extra copy you have of that gene, the tryptase may go up about 9 to 10. So you can imagine the more copies you have, so it's a gene dosage effect, the higher your baseline serum tryptase will be. So in these individuals, they tend to be negative for the KIT mutation. They don't tend to have any evidence of abnormal mast cell aggregates or cell surface markers in bone marrow biopsy. And if you measure urinary markers of mast cell mediators, those also tend to be normal. So they essentially just have this gene duplication abnormality. There's been a lot in the literature in the beginning that if you had this gene duplication, it was associated with a lot of different symptoms all across the board. As time has gone on, I think the thinking now is that most of these individuals are probably asymptomatic, and those that are having lots of constitutional symptoms, a lot of general symptoms, is probably in the minority. Again, that's still being looked at in terms of phenotyping these patients with hereditary alpha-tryptophanemia. But what we do know is if you have hereditary alpha-tryptophanemia and you have systemic mastocytosis, you tend to have greater risk of severe anaphylactic episodes. So that's, if you have a patient with SM, you should consider also checking to see if they have hereditary alpha-tryptophanemia. And in terms of the data sets we have so far, roughly 17 to 18% of patients with SM also have hereditary alpha-tryptophanemia. And in terms of the diagnosis, so there's essentially there's a company that you can send this test. It's basically a throat swab, cheek swab. It's not covered by insurance, so patients typically have to pay out of pocket. So there is some discussion there about the utility or benefits of making the diagnosis. In terms of figuring out what the tryptase level should be in terms of baseline number, if you know they have this, there's a formula here where you can take the tryptase number and then divide it by 1 plus the number of extra copies, and you kind of get an expected tryptase number. So if that's still higher, if the number you get and the number the patient has is still higher than that, then you should consider that they could have mastocytosis on top of it. This calculator and web link at the bottom, so this was a group effort. There's a publication from a couple of years ago. So it's getting at this idea of when we measure baseline tryptase numbers and acute elevations, what should we be using? So the 20% plus 2 formula, which is where you take 20% of the baseline number, add 2 to that, and you're comparing acute versus baseline elevations. That's been around for over a decade. This group looked at that and found that it may not be very specific if you don't take into account hereditary alpha-tryptophanemia in the general population. So when you're trying to calculate, did someone have a significant increase in tryptase, they did a mathematical model and came up with this calculator. And in essence, if you compare acute elevations to baseline, if that ratio is more than 1.685, that's kind of the ratio they found where the specificity really went up. So I encourage everyone to look at this calculator. If you're not familiar with it, you just plug in your tryptase numbers and it will give you like a prediction, like this is a significant increase or not. In terms of, like I said, mentioned, hereditary alpha-thalassemia has been associated with lots of symptoms, but everyone should keep in mind that I think the sense now is symptomatic hereditary alpha-tryptophanemia is probably the minority of patients. So don't forget the broad differential for all of the symptoms that one may come in with. So this slide just kind of illustrates the really broad differential one needs to consider. So if you have someone with hereditary alpha-tryptophanemia and they have lots of symptoms, I would encourage looking at this differential as opposed to just blaming it on hereditary alpha-tryptophanemia.
Yes. Okay. Green wins.
Good job, Green.
Team Green now in the lead, 3,400 to 2,800. Okay, we're going to go back to Dr. Fahrenholtz.
All right, let's go back to Tracy for 800.
All right. Which of the following is a major criterion for the diagnosis of SM? Serum tryptase greater than 20, KIT D816V, or other activating KIT mutation, greater than 25% mast cells in bone marrow aspirate, or spindled or multifocal dense aggregates of mast cells. Okay, 52%. Let's see what Dr. George has to say.
Thanks again for choosing my category. The correct answer is multifocal dense aggregates of mast cells in the bone marrow biopsy. Let's review the WHO 2022 diagnostic criteria. This requires the presence of one major and one minor criteria, or at least 3 minor criteria for the diagnosis of systemic mastocytosis. The major criterion is the presence of multifocal aggregates of mast cells in the bone marrow biopsy and or an extracutaneous organ. And an aggregate of mast cells is defined as 15 or more mast cells in close approximation. The WHO 2022 minor diagnostic criteria are as follows. 1, serum tryptase level greater than 20. 2, the presence of the KIT D816V point mutation or any other activating KIT mutation. 3, abnormal morphology of mast cells. So in bone marrow aspirate smears, that means 25% or more of total mast cells are immature or atypical in shape, or at least 25% of mast cells in the bone marrow biopsy or an extracutaneous organ biopsy are spindle-shaped or otherwise atypical. And the 4th one is the immunophenotype of mast cells, such that the presence of CD2 and or CD25 and or CD30 is present in bone marrow's mast cells or mast cells in blood or another extracutaneous organ. Now, going back to the serum tryptase level, it's important to count for the elevated tryptase level in the presence of hereditary alpha-tryptophanemia, or HAT. In that case, you must divide the basal serum tryptase value by 1 plus the number of extra copies of TPS-AB1. There are a number of pitfalls in WHO criteria for systemic mastocytosis. The basal serum tryptase variability and HAT can affect whether minor criteria are met. So, for example, cases with basal serum tryptase of 8 or greater when other minor criteria are present. Centralized expert bone marrow sample evaluation is suggested. And then there's monoclonal mast cell activation syndrome, which has some pathophysiologic characteristics that overlap with SM criteria, including the presence of the KIT D816V mutation and CD25 expression on mast cells.
Okay, yellow wins.
Way to go, yellow.
All right, Team Yellow, slight lead. Dr. Pongdi?
Yeah, let's finish off Tracy Talks for 1,000.
Tracy Talks for 1,000. This subtype of SM is defined as having met the WHO diagnostic criteria. Cutaneous lesions are absent and there are no B and C findings. 1, indolent systemic mastocytosis. 2, smoldering systemic mastocytosis. 3, bone marrow mastocytosis. And 4, aggressive systemic mastocytosis. Okay, let's see if Dr. George can explain this a bit for us.
Thanks for choosing my category again. The correct answer is bone marrow mastocytosis. Let's review the different subtypes of systemic mastocytosis per the 2022 WHO criteria. At top, you can see there's bone marrow mastocytosis, where these patients have an absence of skin lesions, serum tryptase level less than 125 nanograms per mil, and no B or C findings. Then there's indolent systemic mastocytosis, which is defined as having less than 2 B findings, and skin lesions may be present, but no C findings. Then we get to the last category of non-advanced systemic mastocytosis, that of smoldering systemic mastocytosis, which requires the presence of 2 or more B findings and no C findings. The remaining 3 different categories of systemic mastocytosis are advanced, that of aggressive systemic mastocytosis, mast cell leukemia, and SM with an associated hematologic neoplasm. When you compare the different subtypes of systemic mastocytosis, the symptom presentation varies significantly. In this figure, you can see that in patients with ISM and SSM at left, they have a prominence of mast cell mediator and skin symptoms such as pruritus, flushing, GI symptoms, cardiovascular, and neurologic symptoms, while those patients with advanced systemic mastocytosis at right have prominent organ dysfunction. Let's look a little more closely at the clinical characteristics of non-advanced systemic mastocytosis. In this figure, you can see patient-reported signs and symptoms by the different subtype, such that patients with indolent systemic mastocytosis in blue have urticaria pigmentosa, a lot of cutaneous and GI symptoms, some musculoskeletal symptoms, while those patients in yellow who have bone marrow mastocytosis have quite a bit of idiopathic and recurrent anaphylaxis, as well as other mast cell mediator-related symptoms, including GI symptoms. Whereas those patients with smoldering systemic mastocytosis are shown in red, and you can see they have many more symptoms, including lymphadenopathy, splenomegaly, and hepatomegaly.
Okay, green wins, putting them ahead for the lead. Let's see, Dr. Fahrenholtz.
All right. 3 Ps for 800, please.
3 Ps for 800. Patients' symptoms are often dismissed as anxiety, depression, or of psychosomatic origin. True or false? And we have a video here to explain.
During this time period, a lot of the doctors were dismissing a lot of what I was complaining about, the different allergies to the different foods, the different allergies to the different medications. They just kept dismissing it as anxiety. Anytime I had a very strong reaction or anaphylaxis, it would always be pointed towards I was having very bad panic attack or anxiety and bringing on the symptoms. So it was very discouraging to feel so sick and to have anaphylaxis or to have reactions or to have hives and it be dismissed as just purely anxiety or a panic attack.
Is Mary Jane's experience similar to what you have heard from your SM patients? Maybe we give a quick answer here, Dr. Fahrenholtz and Dr. Pongdi.
Absolutely.
Yeah, I would totally agree. This is spoken by many patients.
Yeah, great. Everybody wins. Excellent. 800 for everybody. Team Green still in the lead, and we are reaching the halfway point here. Dr. Pongdi, your choice.
Yeah, let's go early bird gets the worm for 400.
Whammy.
Oh, no.
You get no question and $400 taken away.
That's not very fair.
All right.
Like file a protest.
Team Green here. Dr. Fahrenholtz, your choice.
So let's go for it into the lead team with by the numbers for 1,000.
All right, by the numbers by 1 for 1,000 here. Okay, which of the following is a predictor of poor prognosis in a patient with non-advanced systemic mastocytosis? Age less than 60, hemoglobin greater than 10, platelets greater than 150, or serum alkaline phosphatase greater than 100 units per liter. All right, excellent. I will pass over here to Dr. Fahrenholtz to talk a bit about this.
All right, great. So potential predictors of poorer prognosis, and essentially it's any abnormal lab. So in indolent, non-advanced disease, we expect normal hemoglobin, normal platelets, et cetera. When we move into the smoldering systemic category, which is more of an intermediate risk for progression, you'll see what Dr. George was referring to as B findings, meaning minor abnormalities in platelet counts and hemoglobin, tendency toward higher basal serum tryptase, higher allele burden of the mutated KIT D16V, and the correct answer here, which was elevated serum alkaline phosphatase greater than 100. Patients who have other associated genetic mutations are also at increased risk for progression, and splenomegaly or hepatomegaly are also findings of smoldering systemic mastocytosis. Smoldering, if there's no organ dysfunction, it's a C finding and a predictor of, or a diagnostic of aggressive systemic mastocytosis if you have organomegaly and organ dysfunction. All right, life expectancy is generally considered to be equivalent in patients with indolent systemic mastocytosis versus control populations. Mayo Clinic data here on the left of the screen shows indolent systemic mastocytosis patients in red, a total of 159 patients in their case series, and expected age and sex-matched U.S. survival is the purple line, and those mirror one another, as you can see. So in that data set, survival looked similar and overlapping to the general population. On the other hand, you can see in green and yellow that advanced mastocytosis has a much lower survival rate from years of diagnosis. There were a few patients with mast cell leukemia, and they did very poorly, as you can maybe see, as the blue line just goes down to zero survival very quickly. Now, European cohort on the right is similar, but there is some separation that you see between the Denmark general population and systemic mastocytosis, although, quote, subtype unknown here. And I'll say that there's emerging data and a lot of discussion now in this area as to whether this may be evolving or may be less reassuring than we once thought. So there's actually a poster presentation tomorrow that's being presented, and it's based on a Southern California Permanente medical group retrospective record review of patients with indolent systemic mastocytosis or aggressive. And in that cohort, again, this is abstract form yet, not yet peer-reviewed, but you can check that out tomorrow. And they suggested up to 19% of the patients in that single clinic experience were moving from indolent to a more aggressive form. Again, that's not peer-reviewed yet, but it is a poster presentation that you could check out, I think, tomorrow. All right, yellow.
Yellow wins.
There we go. That's what I'm talking about.
Team yellow, now in the lead. Okay. Dr. Pondy, your choice.
All right, Team Green, stay focused. Let's start off target avenues treatment for 200.
Okay, first of this category. According to the Touchstone SM patient survey, more than blank of patients with SM take greater than or equal to 3 prescription medications and OTC medications to manage their symptoms. 1 is 1/4, 2 is 1/3, 3 is 1/2, and 4 is 3/4.
Many miles away from home, steps to go.
Okay. Dr. Pondy?
Yeah, this is just a general schematic of treatment considerations. So the main message here is that if you have symptoms, there's a variety of anti-mediator therapies that one would consider that we'll see on the next slide. And then if you have a diagnosis with symptoms, you need to reevaluate these symptoms on a periodic basis. If you have control and the symptoms suddenly become uncontrolled, you may consider reevaluation to see if there's progression of disease. If they're doing well, we don't typically repeat bone marrow biopsies and such. You just continue to follow that patient, and again, we'll follow up a little bit later. On the next slide, it kind of outlines some of the considerations for symptom-directed therapy. Again, as Dr. George outlined, many of the mediators cause associated symptoms. We target those mediators with a variety of therapies. As you can see here, the majority of therapies first line are H1 or H2 antagonists. And then depending on the symptom, you can customize it, as you'll see on the list on the right. We can certainly discuss this more in the Q&A at the end. There may be some special considerations in terms of therapy. As mentioned many times, if you have someone with anaphylactic reactions to venom stings, those patients definitely need to be on immunotherapy. We'll talk a bit later about the use of omalizumab, and of course, everyone should have epinephrine available should an anaphylactic event occur. And again, we'll talk more into more of the newer medications a little bit later in the presentation.
Okay, green wins.
All right, strong word, green.
Coming closer. So green 5,000, team yellow 5,400. Dr. Fahrenholtz.
Let's go targeted avenues to treatment for 400.
Okay. So, newly emerging and FDA-approved targeted therapies designed to inhibit the mutant KIT receptor are in a class known as 1, cyclin-dependent kinase inhibitors, 2, tyrosine kinase inhibitors, 3, Janus kinase or JAK inhibitors, JAK-STAT inhibitors, and 4, axil receptor tyrosine kinase inhibitors, AXL inhibitors. Okay, great. Dr. Fahrenholtz?
All right, so this slide goes through 3 categories of KIT inhibitors. We had imatinib initially, does a wonderful job in clonal hypereosinophilic syndrome, but disappointingly for those of us who are trying to treat mastocytosis, it had really no effect on mutated D816V KIT. Midostaurin came along and did have inhibition of the mutated D816V KIT. Issues with adverse effects, GI issues are pretty common. And next come these selective inhibitors targeting the KIT D816V mutation. Avapritinib first, it is the first and currently the only FDA-approved treatment for indolent systemic mastocytosis. Elenestinib and bezuclastinib are in clinical trials. And there's a hope that TKIs will be effective in reducing or preventing anaphylaxis. There's some early data, case series mainly, to suggest that that is likely the case, but we don't have definitive data yet. Considerations for use of therapy. targeted therapies are now available, so the avapritinib is available through specialty pharmacies, as you might imagine. There are side effects. We'll talk about that more later. And we've already mentioned that a subset of patients that have those smoldering findings with abnormal labs are likely to be at increased risk for progression.
Okay, green wins.
All right.
Tied as we reach the ending of the game here. Okay. Dr. Pongdi, your selection.
All right, this is a good category for green. Let's keep it going. Target avenues to treatment for 600.
Okay. Targeted avenues to treatment for 600. Although not approved by the FDA for use in SM, this medication is often added to the therapeutic regimen in patients at high risk for anaphylaxis who have treatment-refractory mast cell activation symptoms. 1, omalizumab, 2, tocilizumab, 3, adalimumab, and 4, infliximab. Excellent. Okay.
All right, so just a few comments about omalizumab. So again, it's not FDA approved for this indication, but certainly has been used quite a bit for essentially the main issues of recurrent anaphylaxis and also those with difficult to control skin symptoms. As a reminder, we use omalizumab for its FDA indications quite frequently in terms of chronic urticaria, allergic asthma, and now CRS, nasal polyps. So I think most allergists, immunologists are familiar with the medication. But in SM, certainly had good experience with the use of it off-label. You can see the stats here in terms of symptom control. And certainly, again, especially those patients that have recurrent anaphylactic and uncontrolled skin symptoms, definitely something to consider as additional therapy.
Okay. Yellow wins. Yellow, 6,000. Team green, 5,400. All right, Dr. Fahrenholtz.
All right. Targeted avenues for treatment, 800, please.
Okay. Daily double. All right. Which one of the following therapies is FDA approved for the treatment of indolent SM? Saralimumab, midostaurin, avapritinib, or omalizumab? Okay, avapritinib.
All right, so as I mentioned just a moment ago, avapritinib is the only FDA-approved treatment at this time for indolent systemic mastocytosis or non-advanced mastocytosis. It did meet the symptom score target that Dr. George reviewed earlier in more detail. That symptom score spanned those 11 categories with a top score potentially of 110. All patients were on standard therapy, such as antihistamines, and then they were randomized in a 2-to-1 fashion to avapritinib or placebo. And avapritinib, as you can see, was superior to placebo treatment and decreased in the total symptom score at the 24-week mark. So key secondary endpoints showed that it was decreasing mast cell burden as well, with a reduction in serum tryptase of greater than 50%. So the y-axis is the patients achieving greater than 50% reduction. 54% achieved that with avapritinib versus none of the group on placebo. Bone marrow mast cell aggregates also decreased. KIT variant allele fraction, or what we say KIT VAF, was also diminished on treatment. And I've already mentioned the symptom scores. So in terms of treatment and the specifics of it, it was approved last May, and so really early on in establishing this as the standard for indolent systemic mastocytosis, not symptomatically controlled or perhaps with those risk factors for progression that we talked about. Not recommended in patients with platelet counts less than 50. It is 25 milligrams once daily on an empty stomach. There are drug interactions with CYP3A inhibitors and inducers. Adverse events most commonly were peripheral or periorbital edema, some dizziness, flushing, and photosensitivity. None of the patients in the trial stopped therapy due to peripheral or periorbital edema. To date, no bleeding episodes have been seen with avapritinib, and there are a few years out in terms of data in this cohort that have continued on open label extension. One of the concerns was bleeding with higher doses, the 100 milligram and 200 milligram doses that were used in advanced systemic mastocytosis. There were some cognitive issues that were not uncommon, as well as intracerebral hemorrhage that's mentioned here. And so we want to be mindful of that. That hasn't shown up yet, but we are early, so we can't say that that would never happen, of course, with a new therapy. We discussed kind of monitoring of therapy. There's no package insert absolute recommendations, but following CBC with differential, comprehensive metabolic panel, and these patients are going to be monitoring serum tryptase as well, somewhere in the order of 3 to 6 months, and at least every 6 months thereafter.
Okay. Green wins.
Excellent.
So, green, jumping ahead with a daily double. Dr. Pandi, your selection.
All right, let's go for the jugular here. Target avenues of treatment for 1,000.
All right, targeted treatment for 1,000.
Come on, Yellow.
Which of the following investigational therapies selectively targets the KIT mutant receptor? You can select all that apply. So 1, midostaurin, 2, imatinib, 3, elenestinib, and 4, bezuclastinib.
All right, this is a great topic. I think this is an exciting time for our patients, and that there's a lot of new research in the treatments that we really haven't had for frankly, decades. So this nicely outlines some of the investigational agents that are being studied. You can see bezuclastinib, which is currently in a phase 2, open for enrollment. It's called the Summit trial. You'll see a number of abstracts here at the meeting. Elenestinib is also completed a phase 1. The phase 2 part of the trial is open probably later this year. They've called it the Harbor trial. There's also a phase 3 trial for mastocytosis. And you can see other phase 2 and phase 1 trials that do not target the KIT receptor, but target IL-6 and cyclic 8. But all that to say, it's an exciting time for us in terms of providers that we can offer more for our patients, and obviously great for our patients. I just want to touch on a couple of these agents. So for elenestinib, again, this was the Harbor trial in part 1. So some key features about it: it does not penetrate the CNS. Again, it also selectively inhibits the KIT mutation. This is some of the part 1 data you'll see in the chart. So similar to avapritinib in terms of the secondary endpoints, tryptase levels went down, the VAF fraction decreased. Bone marrow mast cell burden improved, and symptom scores improved, all in a dose-dependent fashion. So we'll see how it goes as the trial expands, and again, that's anticipated to occur later this year. Another exciting drug that you should be aware of is bezuclastinib. So then this is the so-called Summit trial. So they recently released the part 1 data, and again, very, very encouraging. Also had minimal CNS penetration, very high selectivity for KIT mutation. And in terms of their endpoints, similar endpoints in terms of symptom improvement, mast cell burden, and safety, very encouraging data all across the board at a 12-week time point. No significant adverse events, so safety looked very good as well. So as I mentioned, part 2, the trial is now open, just opened a couple of weeks ago or so. So the red highlighted really has the key findings from part 1. So again, very encouraging, very exciting for our patients that this trial is happening. And again, we'll see what the results look like as the trial expands.
Okay.
All right, green.
Green wins. Team Green out to a big lead now, 8,000 to 6,000. Dr. Fahrenholtz, your choice.
Okay, 3 Ps for 200, please.
All right, 3 Ps for 200. Free parking, $200. No education whatsoever. Team Green, 8,200. Team Yellow, 6,200. Everybody gets money.
Oh, I think yellow, that should just be for yellow.
I think you get to choose again here too, right? Is that correct with the free parking?
I hope so. Buy the numbers for, or 3 Ps for 600, excuse me.
We're going to do by the numbers for 600. All right. On average, how many healthcare providers do patients with SMC before they receive the diagnosis? Number 1 is 9, number 2 is 6, 3 is 4, and 4 is 2. If that's confusing with lots of numbers, you guys can read here. All right.
Deep space time, great design. With this time.
Okay, so a nice spread here between 1 and 2. Dr. Fahrenholtz will let you explain a bit here.
So as we're aware, suboptimal identification and delayed diagnosis increase patient burden in mastocytosis. It's a rare disorder. The symptoms are quite variable, with some patients showing up with primarily GI symptoms and or cutaneous or isolated severe anaphylaxis. And really, as Dr. Pongi pointed out earlier, having a high index of suspicion is important. The answer here was 6 healthcare providers. Median time from symptom onset to diagnosis in systemic mastocytosis is approximately 9 years. So check serum tryptase and think about this in patients as they come in with somewhat unusual symptoms sometimes, so that high index of suspicion, again, is really critical. So systemic mastocytosis has significant impacts on quality of life. We've touched on this before, and you can see across all categories here, percentage of patients in patient surveys show that people are limited in work and other daily activities, hobbies, leisure time activities. They also report interference with family life and social activities related to their disease in the vast majority of patients. Far right of this is employment changes from a separate survey here, also referenced at the bottom. But over half of the patients at least reduced work hour, 27% quit their jobs, and 16% reported being fired from their jobs due to their limitations of their disease.
Okay.
All right, Yellow. Now we go.
Team Yellow, 6,800. Team Green, 8,200. We are approaching the end here. Dr. Pongi, 3 questions left.
Team Green, stay strong, stay strong. Let's go 3 Ps for 400.
Okay, 3 Ps, 400. Which of the following is not one of the recommended routine monitoring tests every 6 to 12 months for patients with non-advanced SM? 1, serum tryptase, 2, CMP, 3, CBC and DIF, and 4, MC, mast cell immunohistochemistry panel. Okay, 78%. All right, Dr. Pongi.
Excellent. So just want to touch base quickly that as we've seen on a number of slides, our patients have lots of potential symptoms and complications from their disease. And I really encourage everyone to form your own multidisciplinary team and wherever you practice. and really get a lot of people involved. Your patients, I'm sure you're aware, have lots of needs for different resources, and you can really be that point person that help your patient, the coordinating person between all these disciplines, and they certainly can involve quite a few. But you're going to be the knowledge expert to help direct all the traffic. So your patients are looking to you to do that, and you have the ability to do that. So please keep that in mind. In terms of the routine monitoring in the question, essentially here you'll see it at the top, tryptase level, CBC differential, and metabolic panel. Now, these essentially to make sure there's no signal of progression. As Dr. Farrell's nicely outlined, we don't typically expect those of ISM to progress to more advanced disease, but it can happen. And periodic monitoring of these laboratory studies can help make sure that doesn't happen. But if there's an abnormality, progression may need to be considered. Obviously, you want to do your physical exam and make sure there's no signals there. And again, as we've talked about, don't forget to ask about quality of life issues, because you're going to be probably one of the few people in healthcare that really understands the disease. This last point here, in terms of DEXA scan, so remember, patients with ISM are at risk for osteopenia, osteoporosis. We've seen that mentioned as a red flag on history if you see that in a younger patient. So getting DEXA scans at baseline and following that is something that you don't want to forget. And again, the main message here is that symptoms worsen or change while they're on the same therapy, or if the lab results change, you may need to really think about some reevaluation process.
Okay, yellow wins. So 2 questions here, and we're running a little bit short on time, so we're going to speed this up. Dr. Fahrenholtz.
So let's tie it up here. Early bird for 1,000.
All right. Non-advanced SM subtype that is noted for its high risk of anaphylaxis is? Okay. Maybe a little bit of education on this one would be useful.
All right. Number one, as we know and we've touched on, patients need to know how to treat anaphylaxis, and knowing to lie down, of course, if you're lightheaded, tachycardic, signs of hypoperfusion there, and really carrying 2 epinephrine autoinjectors to manage symptoms, and knowing to go to the emergency department with any severe persistent symptoms. Adding omalizumab with recurrent anaphylaxis, we've discussed. And in terms of risk of anaphylaxis, bone marrow mastocytosis, so indolent systemic mastocytosis without cutaneous lesions of urticaria pigmentosa, that's the answer here, looks to be the category with the highest risk of anaphylaxis. Venom-induced anaphylaxis, I think we've talked about this and talked about HAT being an associated risk factor. And yeah, I think we'll just move forward. But venom immunotherapy here is considered lifelong. And yellow, all right.
Yellow wins. Okay. Oh my God. It is tied. It is tied tonight. You have no choice here, actually.
It's all come down to this. For me to stay for this conference for the next couple of days, please think hard about this.
3P, 600. All right, let's go. Where can patients with SM find support for resources for living with this disease? These are 3 different options here, and 4 would be all of the above. Okay, 83%.
So I think everyone in the audience would know this in terms of any of the conditions we treat, but along with SM. But patient education is critical. A nodule patient usually knows more than anybody else in terms of that they see in the healthcare system. So please, as much time as you spend on education, and it's outlined here, especially in terms of anaphylaxis action plans, what to do to the emergency department. These are key features. In terms of the support groups, we'll see here on the next slide, in a couple slides, but here, there's a number of support groups available. I encourage all my patients to investigate these, especially the Mast Cell Disease Society. They're very good about connecting patients with patients. Many patients feel isolated, I'm the only one that has this condition, but connecting them with others is extremely beneficial, especially for mental health and wellness.
Okay, green wins.
All right, great.
All right. So I think that means Team Green coming out ahead slightly as the winners here. So summary, we talked about much of this. I'll just let everybody read this for one quick second here, and then we have a couple of post-test Q and answers. We do have to make sure everybody was paying attention to us and not focusing on winning their Jeopardy game. So post-test question 1. KIT D816V mutation is found in approximately what percentage of patients with non-advanced SM? Okay, excellent. People are listening to Tracy. Okay, post-test question 2. Keith, the 59-year-old man, presents with 2 recent episodes of anaphylaxis, jellyfish sting and contrast eye. In a follow-up with his allergist, Keith's serum tryptase was 23.8 nanograms per milliliter, but he did not have any skin lesions. Peripheral blood genetic testing revealed that Keith was positive for the KIT D816V mutation. What would be the appropriate next diagnostic step for Keith? Excellent. Okay, 96% correct. Post-test question 3. And these are questions we've seen before too, so we would expect high percentages here. Newly emerging FDA-approved targeted therapies designed to inhibit the mutant KIT receptor are in a class known as blank. Excellent. TKI, so tyrosine kinase inhibitors. Post-test question 4. Which of the following therapies is FDA approved for the treatment of ISM? That seems like fishy. So the correct answer, the only FDA-approved medication is avapritinib. The Cogent folks are over here. I saw bezuclastinib had like 80% on one of these, so there may be some funny business. All right, we're going to go to post-test question 5. For what percentage of your patients with non-advanced SM whose symptoms are uncontrolled using standard of care therapies, such as antihistamines, cromolyn sodium, will you now prescribe a TKI to treat their mast cell burden? Okay, 54%. And there's some flex in here. This is an individual patient discussion, so I don't know that there's a correct answer to this one. But that is what the approval criteria is for. All right, so ask the expert. So we are running very short on time. I have a pile of questions here, and we got about 3 or 4 minutes. So we're going to try to go through 1 or 2 of these questions. Maybe I'll start with Dr. Fahrenholtz, and then I'll hand one over to Dr. Pongdi. So first question, this one's for Dr. Fahrenholtz. For symptomatic patients, do you need to first confirm the genetic mutation before prescribing a targeted therapy? So do you need to know that you have a KIT D816V before prescribing targeted therapies?
Yes. Yes, so we would do the D816V kit, bone marrow biopsy, establish the diagnosis, and then move forward with the targeted therapy.
Yeah, they're approved for indolent systemic mastocytosis, so you do need to have a diagnosis of indolent systemic mastocytosis. It can be used in patients without the mutation, but they do definitely need a diagnosis of ISM. Okay, this question is for Dr. Pongdi. Aspirin or NSAIDs can be a potential treatment for SM, but can also be a trigger for an acute event. Any special considerations when starting these drugs? And Tanai comes from the place of aspirin and NSAIDs at Mayo, so you're a fantastic person to answer this question.
Yeah, certainly lots of patients get recommended to avoid those. A lot of this is clinical history. Just asking have they ever had a problem taking, and NSAIDs typically, most people have tried ibuprofen or whatnot. And generally, I find the answer is yes, I've taken that before. And so you could consider measuring your prostaglandin levels in the urine, see if that's elevated and such, target that aspirin therapy. We usually start with baby aspirin at first. If someone says they've never had it before, you could consider starting with baby aspirin in the clinic under observation just to make sure it's okay.
Perfect. Looks like we have time for maybe one more question here. Dr. Fahrenholtz, I'll punt this one over to you. NSAID and angioedema or respiratory symptoms are more common with NSAIDs. Should a tryptase be checked in each one? So I think the question here is if a patient has either angioedema or respiratory symptoms related to NSAIDs, should a tryptase be checked?
For any severe anaphylactic episode, so in the immediate setting, yes, you want to look for evidence of mast cell mediated release, but then anybody with a severe anaphylactic event, I think erring on the side of also checking the basal serum tryptase level several days after when you see them follow up in the clinic is important.
Yeah, absolutely. I would also note that respiratory symptoms with NSAIDs, so Tanya Laidlaw and Katie Buckheit at Brigham do a lot of AERD type research. And AERD, in fact, as it turns out, is a mast cell activation disorder. And so many of these patients, when they had NSAID adverse reactions, their tryptase do elevate quite high acutely. We think of nasal polyps as big bags of mast cells. At least I do, but I'm a little bit biased standing here talking about mast cells. All right, one final question with 1 minute here. Dr. Pongdi, could you discuss muscle fasciculations in regard to mastocytosis? Do you see them? Or
I can't say that's been a common complaint from patients I see. I probably don't have much to offer there. I defer to my colleagues if that's something you come see in your practice.
No, certainly do not. That'd be something I would send to my neurology colleagues for further evaluation. That's something that can be a trap, I think, in evaluating patients for mast cell disorders, that broad range of symptoms, but that's certainly not a core symptom, and I would look for alternative explanations.
Yeah, I completely agree. We have several other questions here, several of which are patient-specific questions. I think all of us are happy to discuss these in a little bit more detail, but in the interest of time, we're going to pause. Thank you very much for coming. We appreciate everybody's attention, and congratulations, Dr. Pongdi.
Thank you so much, team. Great. Thank you so much.